Oh, okay. There's that. There's that. Let's see here. Okay. And then that's, I'll get it. Yeah.
Hello.
Hello, Louis. I'm John
How are
Bennett.
you? Yes, I'm
How you,
around.
how you doing today?
Fine. Very good.
Do you know how to screen share and everything?
Yeah,
Okay,
I know.
you
Kevin.
want to test? Do you want to test anything?
Yeah, I'll test my 50.
If you want, you don't have to. If you want, if you let's do it.
Okay.
Let's do it. Okay, let's do it.
Okay. Okay. Let's do it. Okay. So can you see my
Yes, I can.
slides?
Yes.
Okay, that's fine.
Good morning, Salim.
Good morning, gentlemen. How you doing?
Good. How are you?
Fine. How are you doing?
Good, good. Good to see you. Good to see you.
This is Lou
Yeah,
Yi.
yeah.
He's the other person presenting.
Great.
So, are you in the morning?
It's
We
a
are in
morning.
the evening.
It's 8 a.m. in the morning.
Okay, we are 8 p.m. in
I know.
China. Fine, fine. It's a little bit hot in China, it's
Yeah,
summer.
hot everywhere. Very
Uh,
hot everywhere. Yeah.
but
In Miami, it's not
only
hot. It's funny.
in the north half of the earth. Okay.
I see. I see. Okay.
Okay, yeah. You want to make it large screen?
Okay, I will stop my
Yeah,
share.
yeah. Okay, okay. You know how to do it. Uh,
Mom.
Salim, I don't know. I'm doing something wrong with my settings, I think, with Zoom, because I
Uh-huh.
know people are watching it, but they're not coming in the panel. I think I have it set up incorrectly, but don't worry about it. A lot of people are watching. A lot of
Okay.
people from China,
Okay.
especially.
Okay. Great. Great.
And I'll send you those stats. Oh, it's
Yeah.
not just my word.
All right. Happy to hear it.
Okay.
Yes. Is Ben going to be with us today? Is he available?
I never know because he travels a lot,
Yeah.
but sometimes he'll pop in from an airport. Some people are very adept with a smartphone. I'm not too adept. Are you adept, Salim,
Yeah.
at this?
Yeah. I
You
think
have to
so.
be, right? You have to be, right? On the road a lot.
Yeah. You have to be.
Checking to see here. One Lee. Trying to get a hold of one Lee. So you're in Washington now, right?
Yeah. I'm in DC right now. Yeah.
Okay. Takashi, you there?
Yeah.
Good. Welcome.
Yeah. Welcome. Nice to meet you again, Dr. Salim Abdurrauf.
Good to see you. Good to see you, Dr. Takashi. Yeah.
Yeah. Good to see
Okay.
you.
Okay, Salim, you ready?
Yeah.
Okay. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning, and this is Dr. John Bennett broadcasting from Miami, home of Neurosurgical TV. Today we have our Chinese journal, Neurosurgical Journal webcast bi-monthly. And today we're graced with Salim Abdurrauf, MD, a clinical professor at the Department of Neurosurgery, George Washington University. University in good old Washington, D.C. Okay, welcome, Salim. It's all yours.
Thank you so much. First of all, it's my honor to be with you guys, an honor to be John again. Great work with our Chinese colleagues. We're in two very different time zones. It's morning here, evening in China. So I'd like to thank Dr. Takashi and Dr. Louis for being here. I'm going to go ahead and share my screen. I'm going to speak about ABMs today. Just one second. Okay. How much time do I have? Just want to make sure I stick to time.
It's flexible.
Okay.
Whatever you're comfortable with.
Okay, cool. All right. So we're going to talk about AVMs today. And I'm going to share the lessons I've learned in AVM surgery over the years with you to how I think about them, what are the technical issues, and how we manage those during surgery. Isaac Newton once said, if I have gone further, it is because I'm standing on the shoulders of giants. And I feel exactly the same. I've had great mentors and teachers in my career. And Professor Gus Malik in the United States, one of the largest theories in AVMs in the world, training under him. And of course, then being under Professor Yashigil, who needs no introduction. So one of the things that I've learned early on in dealing with AVMs is that a sharp dissection is much better than a blunt dissection around the vessels that supply AVMs. And it is, so this is one of the things that I've learned over the years is to sharply dissect AVMs and the vessels around them instead of to try to bipolar and separate these vessels, which I believe is more dangerous. Okay, so sharp dissection is a way to go as we deal with these vessels, micro scissors, and so forth. But that is the idea that I want to talk about. Okay. For deeper AVMs, the best way is to follow the main draining vein to the nidus. Okay, because with deeper AVMs, you don't see them on the surface. If you look at this AVM here, once you expose this, you will not see an AVM here. So what's the safest way, especially in eloquent areas of the brain, that you're going to follow an AVM into its nidus without, of course, doing significant resection of the cortical surface here? Okay. So you see, this is a vein I'm interested in right there. So let me show you how I'm going to use this vein as my highway. You see, I see the vein. I don't see the nidus here. The nidus is all deep. So let's combine our sharp dissection that we talked about. Very sharp dissection. This vein is going to be my friend. Okay. Instead of trying to, image guidance, doing cortical resection, all this stuff, no. That's not a smart idea. What you need to do is sharply open the sulcus here and sharply dissect around the main draining vein, okay? And that takes you down into the nidus itself and to dissect. This is the feeders and stuff, and it brings you down there. The other thing is you got to be very careful in larger AVMs, especially for our trainees, who are watching this, the relationship of the nidus to the bony anatomy. If you look at this AVM and this young man, I think there's something very important. I'm going to play it first, and I'm going to come back to it to show you how a case can turn into a disaster very quickly. All right. What is the problem here? The problem is very obvious up front when you look at the first scan here. If you can come down on this CTA, this aneurysm is embedded in the bone itself. If you do not notice that, and you say, okay, let me do a craniotomy, and I'm going to go ahead and, just do my surgery, even at the opening, this can come into a complete disaster. So the idea is you have to recognize this kind of stuff very early on, how you dissect around it, and how you're going to be able to do your craniotomy without injuring that venous aneurysm that are stuck in the bone itself. So noticing these subtle things early on is critical for the safety of the operation, okay? So this is the AVM here. Let me show you that aneurysm in a minute. So this is the AVM, sylvian fissure, okay? Let's see if we can see this large aneurysm here. So this is, yeah, this is that large aneurysm right there. Let me show you. You see, this is superficially, this is a dura. The aneurysm is completely embedded inside the dura in the bone. So the way I planned the craniotomy was very careful not to, in the craniotomy, involve this area up front. Now I've got this big aneurysm. I can deal with it. It's not a problem. The problem is if you did not plan just the opening where the aneurysm is going through the dura into the bone, that could be a very dangerous situation, okay? Now you see I'm very easily able to handle this. It is not a problem. I've got all the way around it. It's not an issue, and you see I am getting rid of the whole aneurysm, okay? No problem. But at the point I'm trying to make is that the opening could have been a major disaster had we not recognized this early on. Now I've got it all. It's not a problem, okay? Now I'm cutting that whole aneurysm out and removing it, okay, with the nidus, all right? Next, as I grew up in this specialty of vascular neurosurgery, there are times you do everything perfectly, everything perfect during surgery, the monitoring, everything. The patient wakes up with a deficit. What is the problem? Why does that ever happen in AVM surgery? So that's the next step I want to talk to you about. When we look at the largest reviews of intraoperative neuromonitoring, SSAP, motor evoked potential, EEG, for vascular neurosurgery for aneurysms and AVMs, we're finding that the sensitivity and specificity, SSCP, you know, you're talking about up to 20% false positive and negatives, okay? So that's a pretty significant portion of the patients who are having surgery under intraoperative neuromonitoring where you are getting the wrong information. And you're making decisions based on that information during surgery, okay? So what is the problem during AVM surgery that can get us in trouble, okay? Well, essentially, the biggest single issue is, of course, AVMs have the feeders coming in and the veins coming out. But at the same time, you have these vessels around the AVM sitting right here, arterial vessels, which are normal vessels. They are bystander vessels. They may look like feeders sitting around this area, okay? And you're deep in an AVM under a microscope. You cannot tell the difference. And you're working deep in a deep corridor, and sometimes you have to coagulate some of these vessels because you do not know. Now, if one of these vessels you coagulated happened to be a normal bystander vessel, and you happen to be, let's say, in the motor area of the hand motor area, you're going to have a deficit, okay? That is a problem in AVM surgery, that a lot of times these normal vessels are around the nidus that are supplying eloquent cortical areas or subcortical areas cannot be distinguished by looking at them, okay? So this is a problem that leads sometimes to deficits in AVM surgery. So how are we going to avoid this situation? Well, it's based on a simple principle. If you occlude an AVM vessel, you will have no deficit, zero, because this AVM vessel feeders are only supplying the AVM nidus, okay? So you know they're not going to have a problem. If you occlude a vessel supplying, let's say, hand motor area, you're going to have a deficit, okay? So this then helps me what I'm going to do next. What I'm going to do next is this. I'm going to go ahead and put a temporary clip on this vessel because I'm not sure. And I'm going to test the patient with the patient awake. If the patient has no deficit, that means this is a purely arterial feeder to the AVM. I have no problem. If I put a temporary clip here and the patient suddenly cannot move their hand, I know 100% that this is a feeder, not a feeder to the AVM. It's a normal vessel, and 100% that it is not an AVM feeder, because you cannot. It's not a binary. It's a binary issue. Either you are a feeder to the AVM or you're going to normal brain. There's no halfway. Okay, that is 100% for sure based on the anatomy of AVMs. All right. So using this principle, let's do the next thing here. So look at this patient, for example. This is an AVM in the motor strip. All right, right there, AVM supplied by the MCA. Very important things to notice here, by the way. Okay, especially for the younger neurosurgeons. This AVM, of course, is being supplied by MCA branches, cortical branches. Fine, but it's also being supplied by deep lenticulostriate feeders going right into the AVM, going through the internal capsule area to supply the AVM. Now, remember what I just said. There are normal vessels here that's supplying normal hand motor area, within the hand area here. And here, there are normal vessels supplying the internal capsule that apply the arm and leg and everything else. We've got to know which vessels are supplying just the AVM and which vessels are supplying normal cortical areas here and subcortical areas. All right. So let's see how we're going to do this. So let's go here. So you see this is a motor right in here in the motor strip, an AVM center right here. Okay. So that's a motor strip right there. And this young lady who has had previous radiosurgery because the motor area some 2.5, 3 years ago at another institution in the United States. Then she had a hemorrhage, exactly about 2.5 years later, small hemorrhage. That's why she was sent to me, because she had already had hemorrhage and radiosurgery. Okay. So now I'm dealing with this difficult situation. Young lady who's an executive of a company, so she's fully functional.
I don't watch movies. I don't watch movies.
You see, the patient is very comfortable. She's very awake. You see this thickened arachnoid because she's had 2 hemorrhages in the past. All right, very comfortable. So what is my plan here? Let's look at this.
Awesome.
I'll let you be home.
Okay, you see this vessel.
Gotta catch up.
I like to really talk to the patients because not only because, I'm just want to talk to them, it tells me everything that's going on and how the patient is doing in vascular neurosurgery. It makes me very comfortable, all right, when things are going okay. You see, the problem is this. There's this vessel that I'm talking to you about. So these are the veins. There are vessels here. There's this vessel that dips in deep, but also goes this way. I'm right in the motor area. How am I going to know 100% for sure that this is an AVM vessel before I take it, or I'm going to cause a deficit right up front in the beginning of the surgery? Okay.
Better than any movie.
Okay. So what I do, I'm going to put a temporary clip on this vessel. All right. Now I'm going to test. I'm right in the hand motor area right there.
Okay.
She's doing great. That means I can take that vessel because it's 100%. It's an AVM vessel. There's no question about it. Okay. So I do that. Perfect. Similarly, when I get deep, those lenticulostriate feeders, when I'm not sure if it's a normal vessel or a feeder to the AVM, of course, now I'm deep at the lenticulostriate feeders. I have to check the arm and leg. Okay.
Can you please? Perfect. Uncode.
You see, I'm checking 100%. So this is the idea of how we do this kind of surgery. And this is a resection of that AVM and right from the motor strip of this patient. Okay. I knew at every step what I'm doing. I knew the risk, everything, because she was never under general anesthesia. Okay. she is going home in 2 days, because if you have your appendix out, you may stay in the house for a couple of days because you are under general anesthesia. But this patient has a post-operative CT scan, never under general anesthesia. Okay, so that's the next advance in AVM surgery. Okay. So this is another patient, again, similar situation, just to make the point, motor strip AVM, okay? This is a patient coming from the Gulf region. She is a young student at the university in Riyadh, and she was sent to me because she also had a small hemorrhage. She was sent to France, and a very astute endovascular people there looked at this and said, this is too high risk in a young patient who is neurologically intact to embolize this AVM or try to embolize it. So that's when the patient was sent to me for open surgery, okay? So she saw a lot of people before she came to me, all right? But the same thinking, okay? It's a motor strip AVM, same challenges we have here, folks, okay? Same exact challenges we're gonna have. I'm gonna show you. You see this AVM? See, this is not only an AVM that's been supplied by the MCA branches, but what you're seeing here, this is very important to notice, okay? When an AVM is supplied by choroidal vessels coming from the ventricle, that is a red flag. You have to be very careful in this situation, because the only way this feeder is getting to this AVM is going through, again, the centrum semiovale, is going through the internal capsular fibers. That's the only way it's going to get from here to there, okay? So you got to be very careful right there. This is just a technical point I'm trying to make just to that. So what's happening here? Let's look at the same thing. You see this here? You see, that's the AVM. But what I just showed you a second ago, the vessels coming from the posterior circulation from PCA, lateral lenticular, lateral posterior choroidal, is going to the ventricle, and then it's passing through here to go into the AVM. What is this space right here? Well, if you injure this space, the patient is going to be paralyzed, okay? So how am I going to know the vessels that are supplying the AVM, and I'm going to know the vessels that are supplying the internal capsule? There is no way in the world you can know this during general anesthesia. There is no test in general anesthesia that can answer that question, all right? So I'm just being frank with you about why I'm pushing this, why I'm explaining this, okay? There is no such thing in a general anesthesia that can answer that question for you, okay? There's no technology, all right? So let's go. So we're doing all this stuff, you know, we're looking at the lesion, the internal capsule, we're figuring out where it is and so forth. That's great. I mean, that's fine, but what I said earlier is more important than all this stuff, okay? But that's fine. Same thing, this lesion is deeper, not like the last lady's on the surface. What am I gonna do? Build on the lessons I've told you so far. I'm gonna follow the main draining vein. This is a central sulcus, all right? Central sulcus. I'm gonna, again, sharp dissection, follow the main vein. Then what was the third thing? We're gonna examine for those vessels for functional areas, okay? So we're building step by step and everything I've told you so far, all right? So those are the central sulcus vessels, all right? I'm gonna open around the main draining vein and go down deep. So this patient, of course, she's from overseas. She does not speak English well. We have a translator in the room who's gonna be talking to her. Oh, you see? Every vessel I'm checking that I'm checking for, okay. I'm checking the motor area, the functional areas for every vessel. You see, this is those, right. I'm in that capsular area now, okay? I've tested this vessel, made sure it's an AVM vessel, not a vessel to the capsular area, you see? And we're checking the legs, of course, because we're in that area. I know 100% before I take this vessel, 100%. That I'm not going to cause an injury, all right? All right, so this is the last vein. All right, that's the AVM, all right? I was a visiting professor in the country of Saudi Arabia. You know, a year later, this is her little brother and father, and she's doing great. She went on to finish her university. So these little steps, you know, are very important for the safety of surgery and to know your outcome while you're doing the surgery, not surprised and shocked after the patient wakes up from general anesthesia. The problem is, when you see it after the patient wakes up, as you know, it's too late. There's nothing in the world you could do about it at that point, all right? What's the next point? The next point I want to make has to do with the draining vein, the last draining vein, okay? This is a young patient who had a very large hemorrhage, was in the ICU from this AVM. We had to remove his blood clot first and then deal with the AVM at a different stage. So what you're seeing here is a very large vein going inside the ventricle and going deep drainage into the vein of Galen, all right? So this next lesson I'm sharing with you is a very important one as well. Okay, you see he had a big craniotomy. He was herniating when he first came in. We removed the blood clot. Now we're going in to do the surgery. So this is the two ACAs, the A1s, that were coming down to where he had this massive blood clot here. Of course, the optic nerves, chiasm down here, okay? So we're coming down to this nidus. Now, you see, I'm coming down. This is in the frontal horn, okay? We're right in the frontal horn where the AVM extends, all right? This is our friend, the large draining vein. I have taken all the arterial feeders. What am I doing? This is a technique that I like to do in AVM surgery when I'm down to the last draining vein, which, of course, in this case, is big vein. Am I going to just go and take it? No. What if there are still some feeders and stuff that you didn't know about? I hold the vein with my bipolar. Just hold it for 30 seconds to a minute. If I'm holding it closed and everything is quiet, nice, no problem, no problem. What if I'm holding this vein, suddenly I start seeing bleeding and swelling? That means there are feeders that I could not see are still working. That means I should stop and go work more, okay? So this is a little thing I'm sharing with you, is holding the last vein with your bipolar, just like this. You're just holding it, okay? You're doing nothing, just holding it sitting there. Everything looks great. I'm not seeing any problems. I'm not seeing bleeding. I'm not seeing swelling. I don't see anything, okay? Patient is doing fine. I'm speaking with him. There's no issue, all right? So now I can go ahead and clip that vein, the last draining vein. You see that? So this is the technique that I'm sharing with you to so that you can use it for AVM surgery, and it's very helpful. Okay. Well, how about neurological testing? Again, going back to the idea of general anesthesia. Well, there are things you cannot even test with the EEG SSCP motor evoked potentials. One of them being the level of consciousness. There is no intraoperative neuromonitoring test under general anesthesia test for consciousness of the patient. Okay, or there is no test that can test for cerebellar function, pica, ICA. There is no testing for the cerebellar function. Okay, let me show you. So this is a patient who has this Vermian AVM, large AVM. Okay, right there. All right, and what you're seeing here is this AVM is being supplied by pica and ICA right here, and this is the AVM during surgery. All right. So how am I going to do the same testing that I did for the other patient? Well, same principle applies, folks. You see?
Yes.
I have this temporary clip here. What am I doing? We're testing cerebellar function. Hand to nose, the two legs, coordination, everything is being tested the same exact way. Okay, so the same principle applies. Okay, so that's how we can advance awake surgery for complex microvascular surgery, by doing very specific testing to that specific vessel and its orientation right there. Okay, so as you see here. The concept of partial treatment of AVMs should be completely avoided. Okay, AVMs is like being pregnant. you're either pregnant or not. I heard from this very experienced neurosurgeon in the United States, Dr. Dan Barrow. He used this example. It's the patient is, I mean, the AVM is, you're either pregnant or not. There's no halfway. By you making the AVM slightly smaller does not decrease the risk of the AVM, okay? So this is a patient, young patient, that was sent to me. She was, when she was 10 years old, she had an AVM. She had multiple embolizations and radiosurgery. This was a very resectable AVM at that point, okay? This is a intrahemispheric surface. You could go in and resect this AVM, but multiple embolizations over time, over months and years, okay? Now she comes to me. She was sent to me because she had a hemorrhage. Look at what happened to this, what would have been a simple AVM to remove surgically in the parietal area. Now, because of the multiple embolizations, the AVM, instead of getting blood flow from the cortical vessels, getting blood flow from the basilar and the PCA, and now it is deep in the posterior third ventricle, okay? In the area we call the velum intrapositum. Now this is a very complex AVM. It's a different ballgame, okay? So this is what I'm saying. AVMs is better not to mess with them. Either you have a center and the experience who can just remove them. To mess with them over years like this is not a good idea because you're going to make it very, very difficult, okay? Now she needs surgery, but the level of surgery she needs is a totally different level, all right? So this is a surgery I'm doing. I'm inside the ventricle here, same principles we talked about before. These are the feeders coming into the AVM. This is the choroidal feeders, okay? I'm inside the trigone here, okay? I'm doing the same thing with the awake testing, everything I showed you so far, okay, with the patient. Everything I'm testing, making sure 100% that I'm not risking in a high risk area. Same thing. What am I doing here? Holding that vein, like I showed you, the last vein. Same principles. Awake testing, everything that we talked about so far is what we have going on here, okay? And then I'm checking all the deep area, make sure there's no feeders left, nothing like that after that. Okay, and that's what it is. This is immediate post-op CT scan. This is her angiogram post-surgery showing you the AVM is completely gone. AVM completely gone. And that's her a few months later. She went on to do very great. Now, sometimes you get into the very deep areas of AVMs, you know, these posterior thalamic AVMs, you know, sometimes you have to operate on them if they're young patients who have bled already. There's not a lot of options, but it is a very tight corridor. This is also a very young lady who also a university student who had a bad hemorrhage. She was in the ICU for 2 weeks with bilateral ventriculostomies. She started to wake up, and she's got this AVM here. Now, this is, again, a very difficult situation, but we need to build on everything I've talked about so far, step by step. If we look at it like this, yes, it's very scary, but if we build it based on all the steps from the beginning of the lecture to now, you can dissect this AVM in your mind and figure out how can you safely deal with this thing. So this is the angiogram, this is the angiogram, okay? So now I'm coming interhemispheric, very tight corridor, okay? And what I'm doing here is this is an AVM. This is a normal brain here around me. The thalamus is behind me, okay? You see what I'm doing? This is my left hand with the suction, right hand with the bipolar. I'm only mobilizing the AVM. I'm not mobilizing normal brain at all. Yes, I'm in a very tight area, but if you're in a tight area, you of course cannot be mobilizing the thalamus or injuring the thalamus. The only structure you can mobilize to create space is the AVM itself. And that's what I'm doing here. So that's the next step that I'm trying to, what you mobilize is mobilize the AVM, not the normal brain around it, okay? So this is a large vein of Galen aneurysm there. This is a posterior medial choroidal arteries. Same thing, awake testing. We're doing the whole thing, building on everything to be able to do this kind of work, all right? So every vessel I'm testing, and this is at last. Now, what am I doing? You see, I'm doing the same thing that I did with the bipolar before, but because this is a whole aneurysm, it's very hard to hold it with the bipolar alone. I'm my left hand holding the suction, right hand holding the bipolar, and I'm going to compress this last drainage, which happens to be this aneurysm. Once I compress it and close it, I know I can go ahead and close this thing. You see the same lessons, but a different level that I'm sharing with you to show you how you can handle this situation well. And now you are closing the whole thing well with the clip here. Okay, so that's what's going on here. Closing that AVM. Okay. Now removing the nidus. That's AVM right there. Okay. So that's really how that, and that's her, you know, she went on to do very well. Okay. Now, grade 5 AVMs are best to be conservatively followed. Okay. I do not operate in grade 5 AVMs. I think the risk is too high. There are exceptions. There are things that happen. I'm going to show you a couple exceptions to that, that puts you in a difficult position to do something. This is a young patient that I followed for many years who has this massive AVM that now bled, and he's in the ICU. You see, this is all AVM here. All AVM, all the way down. This whole thing. Okay. That's the AVM right here. Now, this patient had a significant bleed in the ICU, also bilateral ventriculostomies. I've known him for years. I've followed him. Now he has a bleed. This is the next bleed will kill him. And he's young. He's 20 years old. I was placed in a difficult position. I talked to the family. So we decided to go ahead and proceed with the surgery. So this is a large AVM. Same principles we're talking.
Okay? Yeah, he's a cool guy. He's a nice guy.
You're all cool guys, man.
You see, I'm
Think about
talking.
my vision part.
You see, he's asking me about his vision part we discussed. So this AVM, as you know, is very large. It's involving the visual area and the occipital area. It goes up superiorly towards the motor strip. It goes anteriorly towards the mesial temporal lobe. Each area we're going to test separately. And here we're testing his vision as we're dealing with the occipital area.
What do you think of my vision so far?
Your vision is okay so far.
Yeah.
You haven't done anything to it.
You're mine now.
Why did I decide to operate on it?
Yeah.
Because you see, for the years that you and I have been watching this, this is not a simple AVM, and I didn't want to take any chances, but it started acting up quite bad recently, and I thought once and for all we take care of it for you. Because when you just got admitted to the ICU, we had a lot of swelling and so forth in the brain, and I said, you know what, we just can't take any more chances with it.
Right.
So I'm so glad we're just gonna take care of it for all.
Yeah. Get rid of it. Like I said, man, my mom likes you. You're a cool guy, and
All right. So this is this is down now underneath at the tentorium. Okay. So we've got all the way, and that's him post at day 7 in clinic for his clinic visit to remove the staples. Okay. So there are times when you get yourself in these situations, but if we combine all the lessons I have learned and I put them together, I'll do the best I can. The other grade 5 AVM I want to show you again, and normally we would never operate on something like this. This is, again, a guy for many years who had been followed by multiple places in the United States, who clearly had a brainstem AVM, has had 3 hemorrhages in the past, has had radiosurgery, has had multiple embolizations, and because of the hemorrhages and everything, he has got hemiparesis on one side. On the ipsilateral side, he has 7th and 8th nerves that are gone. has no hearing, has got facial paresis, he's got a 6th nerve palsy. Now he comes in with this hemorrhage. So this guy, over a short period of time, number of hemorrhages, he's in the ICU. We thought he was not going to make it. He started to wake up. Now, very difficult conversation with the family, knowing that we would never operate on something like this in general. But the way this AVM has behaved puts us in a difficult situation. This is the AVM inside the pons coming down to the medulla. That's a basilar artery. Direct feeders coming from the basilar artery. Okay, it's the worst type you could ever imagine. All right. So this is the AVM here. It has this a branch coming off of pica that comes all the way up and drains into the AVM. Today, we're not going to discuss approaches. This requires quite extensive Petrus approach with drilling and mobilizing the 7th nerve. But anyway, so this is 2 vertebral arteries. This is a 6th nerve. This is a basilar artery, okay? Now, same principles we're going to apply to everything we have done so far as we come to the end of my talk here. Direct feeders coming into the AVM. I'm testing each one of them with the patient awake, okay? So these are the feeders. Sometimes they bleed. You have to stay calm. You only buzz the feeder, not on the, this is a feeder that's looping around all the way around, coming up. You take it.
Breathe it real hard.
You see, I'm testing every vessel with him. Every vessel that way I know for sure, okay? And you're doing all the principles we talked about so far in this lecture. That's a basilar artery, direct feeding from the basilar into the brainstem. And you're looking at these feeders coming into it, okay? And right there, I'm holding the last, same thing. We're coming to the last that we talked about, holding the last draining vein. I take the last draining vein, same principle, post-operative CT scan, angiogram, pre-op, post-op, AP, angiogram, pre-op, post-op, after surgery. Okay, that's his incision here. He's doing very well. He still has a deficit he always had. You know, he posts a lot of things on social media. Those of you friends with me on social media, he's very active. And, you know, so we were able to get him through this process for this surgery. Okay. I think when we look at outcomes based on advancing techniques, these are some of the largest experiences in AVM surgery with morbidity and mortality. We are decreasing that. If you look at my first 304 cases versus my 206, which employ the awake and everything else, we are significantly decreasing morbidity and mortality of AVM surgery because we're advancing the technique to the next level. It's been my pleasure to be with you. Please feel free to contact me, you know, through this for any questions I can answer for you. I just wanted to share with you my journey in AVM surgery, the small kind of contributions I have made to AVM surgery to make it better and safer for our patients. So thank you very much for having me.
Thank you, Dr. Salim Abdullah, for a nice presentation. So the fine surgery, we have surgery, including awake surgery. This is paper is open for discussion. So is there any questions or comments from the audience? Any questions from the audience? So some, please. So. Okay, so as mobile from my side, so you use ICG for the complete surgery, complete removal. So the hemorrhagic cases, due to the young patients' hemorrhagic case, so it's very difficult to remove the such as a hematoma scar or hemosiderin, and very adhesive, and arachnoid was very thick. So how do you manage to remove the hemosiderin, remove the clot, the scar of the clot, because it would be the cause of postoperative epilepsy. So not only so completely remove the nidus, so other vicinity of the AVM itself is also, how do you think to remove
Yeah, I think your question is very good. I think you remove sharply the capsule of that.
Mm.
And if you are in very eloquent area where you're going to cause
Mm.
injury to the PL surface, motor air speech area, I would not take that risk. I mean, so it's
Yeah.
all a balance. I mean, I'm going to make a balance of what is
Mm.
worth and what's not worth. As long as I got the whole AVM, that was the goal of the surgery. And we keep these patients on seizure medications for a few weeks and follow them. But yes, I will use my judgment depending what's reasonable and what's not.
Yes, yes, that's important. Thank you for the comments. Any other questions from the audience? Some of the newly added Dr. Ahmed Fawad, are there any questions from Afghanistan? Ahmed Fawad, I available.
Ahmad, can you
Ahmad?
speak? He may be in a place where he can't talk. Sometimes he accesses them from the ICU in Afghanistan.
Okay.
That's
Okay, yeah,
that's
Afghanistan.
how much he wants to be at these webcasts. So, well,
And
also,
oh,
go ahead, go ahead.
okay, so I would like to ask another question. So because in the US, so there are many patients from the mother tongue and English, mother tongue and English. So as you're doing the awake surgery, so do you emphasize the mother tongue, mother language, or English? So sometimes,
Yeah, so yeah,
it's
so we
difficult.
have,
Yeah.
of course, patients that come to us who do not speak English or they have more than one language. So
Mm,
usually what we have the speech pathologist involved from the beginning.
mm.
The speech
Okay.
pathologists, they assess everything before surgery, and then they
Mm.
are in the surgery with us, the speech pathologist. And they are,
Okay.
oh yeah, yeah. So usually if it's English, I'm talking to the patient, whatever, but if it's they have their primary language, the mother language, as you said, is a different language, it is the speech pathologist and the translator with us in the room, working with us at the same time.
Okay. That's very important because in Japan, so there are many foreign people are increasing. So ABEC surgery is not only limited to Japanese. So
Yeah,
mainly we performing the Chinese version or English
yeah.
version. Try to induce. So thank you for the good comment, nice comments. Any other questions or comments from the floor, audience? So okay, so we conclude this session.
Well,
Thank you very much for
excuse
the
me,
Dr. Salim.
excuse me, Takaya. I just want to say a word, Salim. Thank you very much for your organization, Walter Dandy. I don't think we even mentioned that. But one thing I can see, Salim, is the numbers of kids participating is lessening. And I think you provided a great way for kids to participate in online neurosurgical events. And I hope to see, we're talking about that, but I hope to see you come back in a big way because
Yeah.
the internet community needs young blood.
Yeah. We're really mentoring the next generation of neurosurgeons around the world. John, thank you for your help with everything. We are really want to provide the best mentorship to our colleagues in the next generation of neurosurgeons around the world. So thank you so much.
Okay, thank you,
Thank you.
Salim. Okay,
Yeah.
Takashi.
Okay. Yeah. Thank you, Dr. Salim Abdullah. So, Dr. Salim Abdullah, the textbook of neuroanatomy, microsurgical anatomy, the good textbook and translated in multiple languages. I'm in charge of the Japanese translation version. So, you can, if you have the opportunity, so you can read it.
Thank you.
Thank you very much for this presentation, Dr. Salim Abdullah. So, let's go to the next paper. So, I will introduce the next presenter, Dr. Long Hu, Southwest Hospital Army Medical University, China, Chongqing, China. And the topic is clot removal with without compressive craniotomy and ICP monitoring. Dr. Long Hu, it's okay?
Hi,
Are you ready?
hi, dear professors and friends. I'm sharing my slides.
Okay,
So
you
can you
can
see?
make it
Can you see it?
presentation mode. Yeah, make it larger. You did it before, I think,
Okay.
at the bottom. Yeah, one of those icons.
Okay.
Yeah,
So
perfect.
okay. Okay. The title of the paper is clot removal with or without decompressive craniectomy and ICP monitoring for supratentorial intracerebral hemorrhage. This is the outline of the lecture. So as we all know, intracerebral hemorrhage is the most fatal and refractory subtype of stroke, with mortality more than 50% 1 year after ICH onset. The hematoma's mass increases intracranial pressure, subsequently compressing brain regions, and thereby leading to brain herniation. Brain herniation can result in severe neurological deficits and even death. The prevalence and mortality of intracranial hypertension were high after ICH. Intracerebral hemorrhage has few effective treatments, except INTERACT-2 and INTERACT-3 trials. In the trial of INTERACT-2, the patients with ICH intensive lowering of blood pressure didn't result in a significant reduction in the rate of primary outcome of death and severe disability. However, ordinary analysis showed the lower modified ranking scale in the intensive treatment. In the INTERACT-3 trial, implementation of a care bundle protocol for intensive blood pressure lowering and other management algorithms for physiological control within several hours of the onset of symptoms resulted in improved functional outcome for patients with acute ICH. For the surgical intervention, which surgical interventions is effective for controlling intracranial hypertension? The hematoma evacuation or decompressive craniectomy, or hematoma evacuation plus decompressive craniectomy. Obviously, the last one is the most effective treatment for controlling ICP. The stitch showed that no overall benefits from early surgery when compared with initial conservative treatment, but subgroup analysis showed that a favorable outcome from early surgery was more likely if the hematoma was 1 centimeter or less from the cortical surface. So they carry out the second trial named Stage 2. The Stage 2 results showed that early surgery doesn't increase the rate of death and disability at 6 months. And the third trial in this field is the MISTY-3. The results show that MISTY didn't improve the proportion of patients who achieved a good responses 1 year after ICH for moderate to large intracerebral hemorrhage. And this year, the ENRICH trial showed that the minimally invasive hematoma evacuation resulted in better functional outcomes at 1 year than those with guideline-based medical management. The effect of surgery appeared to be attributable to intervention for lobar hemorrhages, but not for the deep-seated hemorrhage. And interestingly, also this year, the SWITCH trial provides weak evidence that decompressive craniectomy plus best medical treatment might be superior to the best medical treatment alone in people with severe deep ICH. So, from Stage 1 to Stage 2, MISTY-3, ENRICH, SWITCH, none have identified strongly effective treatment, although some headway has been made in reducing mortality and disability for the ICH, especially for the deep-seated ICH. For decompressive craniectomy, a severe traumatic brain injury was the most common indication for the decompressive craniectomy, including DECRA, Rescue ICP, Rescue SDH trials. Now, in the DECRA trial, in adults with severe diffuse traumatic brain injury and refractory intracranial hypertension, early bifrontal temporal parietal decompressive craniectomy decreased intracranial pressure and the length of stay in the ICU, but was associated with more unfavorable outcomes. In rescue ICP trial, at 6 months, the compressive craniectomy in patients with traumatic brain injury and refractory intracranial hypertension resulted in lower mortality and higher rates of vegetative state, lower severe disability, and upper severe disability than medical care. So in rescue ASDH trial, among patients with traumatic acute subdural hematoma who underwent craniotomy or the compressive craniectomy, disability and quality of life outcomes were similar with the two approaches. So how about the compressive craniectomy for the TBI remains a controversial topic. The results appeared somewhat inconclusive, and which did confirm the complexity in treating severe traumatic brain injury. So the efficacy and the compressive craniectomy for improving functional outcomes remain uncertain in intracerebral hemorrhage patients. Surgical reduction of ICH volume decreases proportion of high ICP and low CPP event. This result is from the post-hoc analysis of MISTI-3. So, to avoid preemptive decompressive craniectomy during clot removal procedure in ICH patients meeting surgical indications, a prospective randomized controlled study to compare the outcomes of clot removal with or without decompressive craniectomy in adult patients with ICH. The trial was a prospective, pragmatic controlled trial involving adult patients with ICH. When the intraparenchymal hematoma volume exceeded 30 milliliter or the patient's consciousness deteriorated, a surgery for the clot removal was performed. This trial was registered with clinicaltrials.gov. Here are the inclusion criteria and exclusion criteria. So in the inclusion criteria, aged 18 to 80 years, a supratentorial ICH, a stable volume of 30 to 80 milliliter, RGCS score of 5 or higher within 72 hours after stroke onset. Randomization treatment. Patients were randomly allocated to the clot removal with decompressive craniotomy or clot removal alone groups. Patients who were assigned to CR group had clot removal with ICP monitoring. Patients who were assigned to the CR plus DC group had clot removal with ICP monitoring, and their dura left open, and there was a non-constricting duroplasty before scalp closure, and their bone flap was left out. The outcomes. The primary outcome was the proportion of unfavorable function outcome measured by the modified ranking scale at 6 months. Unfavorable outcome was defined as MRS grade 3 to 6 at 6 months. Secondary outcomes were all-cause mortality at 6 months after stroke and the proportion of reoperation. Results. Totally, 1,161 patients were screened for eligibility and 204 were enrolled. 102 patients received CR and 102 underwent CR plus DC. Among them, 17 patients who were assigned to the CR group but underwent DC, 22 patients who were assigned to the CR plus DC group but underwent CR. This is baseline. The characteristics of the ICH patients at baseline were similar in the two groups, including the demographic data, clinical features, medical history, radiologic features, and time to surgery, and including external ventricular gene. The primary outcome showed that 92.2% of patients in the CR plus DC group and 81.4% patients in the CR group had achieved an MRS score of 3 to 6. And from the table, we can see there was a significantly difference between two groups. The secondary outcomes, the mortality was as follows: 13.7% among 102 patients in the CR plus DC group and 4.9% of 102 patients in the CR group. Reoperation was reported in 6 of 102 patients in the CR DC group and 4 of 102 patients in the CR group. Safety outcomes, there was no significant difference in the intracranial hypertension between both treatment groups. So we can see the ICP and the CPP. There was no difference in both groups, but definitely there is a elevation in the CRO alone group, but there is no statistic difference. The frequency of complications was also similar among the groups, including the stay in ICU, the hydrocephalus, pneumonia, gastrointestinal bleeding, and something like that. So sample group analysis showed there didn't identify substantial differences. So there is a perceived lack of equipoise regarding the life-saving benefits of decompressive craniectomy for supratentorial ICH and medical management. The optimal timing of surgical intervention in large supratentorial ICH is still unclear. There was also limited guidance from the literature on appropriate patient selection for decompressive craniectomy. So from this trial, we show that clot removal without decompressive craniectomy decreased the rate of modified Rankin scale score of 3 to 6 and mortality in patients with ICH compared with clot removal with decompressive craniectomy. Clot removal without DC was an effective therapeutic strategy for controlling intracranial hypertension in the ICH patients. That's all. Thank you. Professor?
Yeah, thank you. Thank you,
Okay.
Dr. Wang, for the nice presentation. This paper is open for discussions. So, any questions from the audience?
I just
Any
want to
questions
say it
from
was
the
a very nice presentation by Dr. Hui. Very nice. Thank you.
Thank you, Professor Abdullah.
Yeah, and any questions? So I would like to ask you another question from the acute ICH removal is very important emergency surgery, and our emergency department also acute removal of the hematoma is very important. So how long? So within 6 hours or within 1 day? So as soon as possible, we have to remove and lower ICP. And the compressive craniotomy is also same reason for the acute rapid lowering blood pressure. That will be important. So how long? So as early as possible, we not understand very well, but how long? 6 hours or 1 day, or it is tolerant to go surgery? 6 hours or 12 hours or 24 hours?
Yes, thank you for this very good question. In our department, we do the surgeries as early as possible because no evidence-based evidence to show the early or the late surgery bring the benefit for the patients. But from the physiological state, we think remove the clot as early as possible will bring the benefit for the lowering intracranial hypertension to remove the clot, which will lead to secondary injury to the surrounding brain tissues.
Yes,
But
yes.
there is no trial to test early or late which one is good. Thank you.
Okay, thank you. So, any other questions from the audience?
Yeah, Professor Takashi, I just want to ask Dr. Liu a question as
Okay.
well. Based on your evidence-based, is there a difference in right versus left-sided intracerebral hematoma evacuation for the same patient? It was a right or left side from an outcome standpoint.
So I don't get your main point. So you mean
If it was on the left-sided intracerebral hematoma versus it was a right side?
there is from our data we don't see the difference between left and right.
Okay.
Especially, I know in the China most people use right hands, right? So the left brain is the dominative spheric,
Yes.
but there is no obvious difference.
So there's
Thank
no
you.
difference in outcome. Okay, that's
Yes,
important.
Yes.
Thank you. Thank you. So any questions from I would like to ask another question. So sometimes for emergency departments, so we do a butthole surgery, acute butthole opening to lessen the intracranial pressure. Is your institute doing the emergency department? So some other acute ICP monitoring or acute decompression of the butthole surgery, are you performing? Are you doing so?
Yes. The carriage trial was begin the 7 years ago. So in the past years we do the traditional craniotomy, but from 5 years ago we use the endoscopic evacuation. Yeah, so you use the burr hole
Okay.
under the using the endoscope.
Okay.
So we also we test the the ICP during the operation. So before we open the dura, we just open a little hole, let the monitor go through the hematoma center, and we then read the pressure. And after the clot totally removed, we place the monitor in the cavity and then close the scalp and leave the ICP monitor obviously generally 5 days to 7 days after surgery.
Okay.
Thank you.
Okay. Thank you. So, Dr. Jones, so there are several questions from Tanzania.
Yeah, there's a question. Yeah, do you remove even the deep-seated clot? At what time from insult? That's asked from a neurosurgeon from Tanzania.
John Mitchell.
So, can you repeat the question, Professor Bennett?
Yeah. Do you remove even the deep-seated clot? And at what time from the insult of the injury?
Definitely we remove the clot as totally, but we don't ask every single patients to remove the clot completely, because a little bit hematoma residual is permitted, because we need to protect the surrounding brain tissues, especially bordering the hematoma.
Okay, so
Do
you understand the John Mitchell? Okay. John Mitchell? Okay, it's okay. So, yeah, so that would be a good question. So, any other questions from the audience? So, I would like
Go ahead, Takashi. Go
okay,
ahead.
so I would like another question. So the patients with antiplatelets therapy and anticoagulation therapy, how do you neutralize or the emergency surgery?
How do I use what?
How to use neutralize, so to lessen the effect of anticoagulation, hemorrhagic tendency, bleeding tendency. Sometimes anticoagulation drug, anticoagulation drug,
understand.
that would
Yes.
be the drugs.
That's a very important question. Yes. In most cases, we don't use coagulation or any yes, we just use compression. But
Compression.
yes, but in the case of the pulse or arterial bleeding, we need to use the coagulation.
Oh, okay, okay.
Yeah,
Yes.
yeah. Just let me just since there are a lot of people listening. So if the patient is on aspirin or whatever, I think it's important to give something to before you operate on these patients, especially if they have elevated PT, PTT, or if they are on
Yes,
any
yeah,
of the antiplatelet drugs. Nowadays, a lot of the older patients
Yeah.
are on antiplatelet therapy or dual antiplatelet therapy. So it's very important when you are going to surgery that you use some reversal agents before you do an acute
Reversals,
operation
yes.
on a patient. So I think I just want to clarify that.
Okay. Thank you, Dr. Salem Adreso. Nice comment. Okay, thank you.
Excuse me, Takashi, I have
Yeah.
a small question. Dr. Hu, you're in southwestern China. Can you use the map behind you and point to where your hospital is? Because it's not in the part of China we normally have webinars with. Behind you on the wall is a map of China. Could you point where you're at now, Louis?
Your place, the institute is Chongqing,
It's it's in
Dr.
Western
Hu?
China. Western, do you
Western
hear me?
China.
Do you hear me, Louis? I don't know if you can hear me.
Dr. Rangfu?
I
Dr.
think
Rangfu?
he's frozen. I think he's frozen. I think.
Okay. That's frozen. The picture is frozen. So because I would know so Western China will be the Chongqing.
Okay.
We have to. They're very famous in Japan. Also, same Chongqing restaurant. So mooncake is very important, very famous in Japan. In
Oh, is it?
Yokohama, yeah,
Okay.
Chongqing is very important, a big city. Yeah. Due to
Okay.
COVID-19, so Chongqing is doctors acted very well to prevent dissemination
Contain
of
it.
COVID-19. So yeah, so we know we respect those people, Chongqing, the hospital. So they will worked a lot. So the unfortunately the website is closed. Something wrong with closed. So another question from the floor. So John, should we conclude the session?
Yeah. Okay. I think thanks a lot, Salim, and thanks, Louis.
Thank you.
A very active webinar. I look forward to our next one in 2 weeks.
2 weeks, yes, 2 weeks after. So, Dr.
Okay,
Salim, nice
hang
to
on.
meet you again. So, yeah,
Yeah,
you
hang
went
around.
to, you moved to Washington, D.C., George Washington.
Yes, I'm at George Washington University. I'm a clinical professor at George Washington University. Yes.
Oh, okay, okay, George Washington. So, you moved to Washington, D.C.
Yes,
Sure.
you know I was the head of neurosurgery in St. Louis for
St. Louis,
university
yeah,
for many years.
Yeah.
Barnes, right?
I know.
Yeah,
Barnes
yeah,
Hospital.
at St. Louis University Hospital, and now I'm at George Washington in Washington, D.C.
Okay, so yeah, I sometimes I fly to U.S. sometimes. So yeah, I would
would
like
love
to visit. Yeah,
Now,
okay,
of course, we welcome you. We welcome you.
okay. Thank you for
Of course,
nice
that
meeting
hospital
again.
is the
So
hospital they took President Reagan, right, when he was
Yes,
shot.
yes, yes.
Right
That's
to
exact
George
same
Washington.
hospital. Yes, yes, that's exactly.
And I was reading about it. He was quite, he said to the neurosurgeons, I hope you're not Republicans.
Right.
Yeah, he had a sense of humor. Okay, thanks everyone for coming. And I'm just
Thank
going to
you.
conclude
Thank
this
you.
and you hang around. This recording stopping, but I'll still be online. We're still here. I got off